Like I said, so my name is Kristofer Jones. I'm a new sports medicine and shoulder surgeon over at UCLA. Came over, did all my training in New York City, and just moved here 6 months ago. Primarily focus in sports medicine, so a lot of arthroscopic surgery, the way we fix a lot of our shoulder problems nowadays. I do shoulder replacements, so shoulder arthroplasty, and we'll talk a little bit about that because it does pertain specifically to a type of rotator cuff problem and arthritis that's associated with rotator cuff problems. So we'll talk about that a little bit. So every talk should start with one of these. I have no financial disclosures. None of the things that I mention in this talk are financially relevant. So no orthopedic talk would be complete unless you started to build a foundation based upon musculoskeletal anatomy, okay? So in terms of shoulder anatomy, the shoulder is a very complex joint, most mobile joint in the body. It's a ball and socket joint just like the hip, but unlike the hip, it doesn't have the same type of bony congruity to it, so it has a lot more motion. The glenohumeral joint is the joint that we commonly refer to as the shoulder joint. And then there are two other joints that are intimately related. So the acromioclavicular joint is right here, and that is the joint between the collarbone and the acromion. The acromion is this little bone right here that is part of the entire shoulder blade, okay? And then you also have the sternoclavicular joint, which is close to the neck and the head, which would be up here, okay? So in terms of the anatomy of the rotator cuff, there are 4 rotator cuff muscles. The first one is the supraspinatus, which lives up here on the top of the shoulder. It initiates and assists the deltoid muscle with shoulder abduction, so that would be this movement right here. The infraspinatus muscle and the teres minor muscle live here in the back. So this would be the back of the shoulder, lying on top of the shoulder blade right here, and it assists with external rotation, so rotation of the shoulder like this. And then the subscapularis muscle lives here in the front, once again connected to the shoulder blade, but travels towards the front of the shoulder right here and assists different muscles with internal rotation. So this movement right here, okay? So all these muscles work in coordination to keep the humeral head centered on the glenoid socket. The glenoid is the socket of the shoulder. And it's important for all these muscles to be equally as strong and as healthy as one another in order to coordinate function as you move the shoulder around. Any problems with one of these muscles could lead to problems with the other. You know, it's like the domino effect. So in terms of stabilization, all these muscles also work to dynamically stabilize the shoulder. Now, there are static stabilizers of the shoulder as well. So if we look at a layer sort of a picture here, with the rotator cuff being sectioned here, so these are all the tendons that we were looking at before, and you delve deeper under the surface, under the rotator cuffs is an important capsule of the shoulder. And that's comprised of the glenohumeral ligaments, which provide static stability, okay? So there are 2 types of stabilizers. The dynamic stabilizers, which are the muscles, the rotator cuff tendons, and the static stabilizers, okay? The glenohumeral ligaments. And this little function, right, or this little structure right here called the labrum, which is comprised of a material similar to the meniscus in the knee, but just surrounds the glenoid socket in order to deepen it and provide stability to the shoulder. So my general approach to patients with shoulder pain is, this is sort of how I lump them together in just a generalized fashion. When I have patients who are less than 30 come into my office with shoulder problems, it's usually an issue with instability and pathology with that labrum that I was talking about earlier. Patients 30 to 50, it's usually an issue with subacromial impingement, and we'll dive into that a little bit deeper as well. Rotator cuff tendinitis can be a result of subacromial impingement, and patients greater than 60 years old tend to come in with real rotator cuff tears. So not irritation of the rotator cuff like tendinitis, but actual tears themselves that sometimes need to be fixed with surgery. And then the other issue is osteoarthritis, which we'll talk about too. So like any sort of doctor that you go see, you know, there's important points that you want to address when you walk into the office. For me and what I do, A good clinical examination and standard x-rays are going to allow me to make a correct diagnosis in 95% of cases, particularly with the shoulder. Okay? A good patient history and physical exam is the foundation of what we do when you come into the office. So in terms of the patient history, what kinds of things do I like to know from you to get a good sense of what's going on? I want to know the reason for the visit. Is it pain? Is it weakness? Does your shoulder feel unstable? Is it stiffness? Do you have decreased range of motion? You're not able to do all the things that you used to be able to do. Reach into the cupboard for a coffee cup, things like that. Relevant history. What kind? Did you have an injury? Did you fall and dislocate the shoulder? Were you hit by a car? We see that a lot around in Los Angeles. What's your occupation? Could this be related to the work that you do? Are you a carpenter where you're working overhead a lot? What types of recreational sports do you play on an everyday basis? Okay? And then I like to characterize the pain. Where is it exactly? And this is related to, excuse me, where's the pain exactly? And this is sort of, this clues us into the anatomy. When we were talking about the anatomy of the shoulder before, all those muscles and tendons can be pain generators. So where the pain is can actually clue us into what is actually the problem. How bad is it? The time of day. So night pain is actually a very common complaint that people have rotator cuff problems. Pain that wakes them up in the middle of the night, that clues me into a rotator cuff issue. Does the pain radiate below the elbow? Does it make the fingers and the hand numb? That's always going to clue me into maybe this isn't a shoulder problem. Maybe this is a problem coming from the cervical neck, because we have this thing called referred pain, and it's important to ascertain whether or not the real issue is coming from the neck or coming from the shoulder, because pain in the neck can actually be referred to the shoulder. All right? And then effect on your activities of daily living. And lastly, what previous treatments have you had before? What have we tried? I don't want to waste your time. I'd like you to have an efficient visit, and we need to know what kinds of treatments you've had before so we don't go down that same road. So what I start with regards to my physical exam, I want to always have my patients in a gown so I can visually inspect the shoulder. It's important to, like I said before, examine the cervical spine. All of my physical exams start with the spine, okay? I palpate all the anatomical structures that we were talking about before to see if there are any clear pain generators. I test passive range of motion, so what I can make you do when I move your shoulder, and then active range of motion, what you can do on your own. And that can be very different sometimes. And then there are special tests, which we'll go over too, and how they relate and clue me into what's going on. So visual inspection, like I said, you always want to remove the shirt. You want to look at the deltoid muscle, which is the muscle that runs all along the side of the arm here. I want to look at the supraspinatus muscle, that one rotator cuff muscle at the top we were talking about, which lives up here on top of this bone. The infraspinatus muscle, which lives down here. And you can actually appreciate in this patient, there's sort of a divot in his shoulder there. Can you appreciate that? So what he has is atrophy of the infraspinatus muscle. And he ended up being a patient that had a nerve problem that in the nerve, the specific nerve that was supplying this muscle. So he was coming in with pain that was isolated to this muscle because he had a nerve problem. I want to look for skin changes, any scars, previous scars, to look for trauma and clue me into something like that. Like I said, cervical spine is always where I start. I'll check with the range of motion of the neck, and then there are very specific tests that we can do, such as this Lhermitte's and Sperling's test, to decide whether or not you have any impingement of the nerves that are coming out of the cervical spine. That's what can cause the referred pain that comes down to the shoulder. Palpation. So the AC joint right here on the top of the shoulder is an important pain generator in patients with shoulder pain. You can get, that's one of those other joints in the shoulder that I spoke about before, and actually can develop a significant amount of arthritis with just normal wear and tear. So that's an important spot to examine when you're in the office to determine whether or not it's contributing to your symptoms. And then the biceps tendon. A lot of people have pain in the front of the shoulder, and the biceps tendon usually tends to go hand in hand with rotator cuff problems. So we want to definitely make sure that that's not an issue. Range of motion, Like I said before, forward flexion, external rotation, and internal rotation. These are the movements that are going to clue me into what types of restrictions that you have and what's bothering you in activities of daily living. Forward flexion, I know you're going to have problems reaching into a cupboard. External rotation, I know you're going to have problems putting on a shirt, putting on a jacket in the morning. So whenever a patient has limited passive range of motion, I stop the exam. There's no reason to push through pain. I get inaccurate feedback from you, certainly, and that obviously doesn't influence my immediate treatment. Some impingement tests that we can look at with specific regards to the rotator cuff. This was developed by some very famous shoulder surgeons a long time ago, Rich Hawkins and Charles Neer. And we'll go over this as we talk about subacromial impingement, but what happens is when I do these specific maneuvers, the rotator cuff becomes pinched in between the ball and the roof of the shoulder. So this is the ball, here's the socket, and this is the acromion bone, or the roof. And when you lift your arm overhead, it gets impinged, oh, lost my light. It gets impinged between the two, which can cause gradual tendinitis, which could possibly lead to tears with repetitive overuse activity. So how do I test the rotator cuff specifically? I'm going to do a test called the Job's test, where I ask the patient to place their arm like this in abduction, external rotation, and I basically ask them to resist me. And with that forced loading of the supraspinatus muscle, I can tell whether or not the supraspinatus is involved in the pathology. The other test that I use is the drop arm test. So if you can lift your arm and hold it here, and I ask you to slowly lower it down, and you can't do that, it just gives out on you, I know the supraspinatus muscle is involved in the pathology and some of the pain that you're having. Infraspinatus testing is that external rotation, okay? I'm going to ask you to basically push against me as I resist you externally rotating your shoulder. Any pain with that typically clues me into the infraspinatus, or that teres minor muscle, which were those two muscles in the back of the shoulder, okay? And then the subscapularis is the internal rotation. So there's a special test called the belly press test, as well as the lift-off test. And if any one of those are positive, I'm able to basically break you from internally rotating your shoulder. I know that a lot of your pain may be coming from the subscapularis muscle, maybe tendinitis, maybe a tear. If there's a lot of weakness, you can get that atrophy over time from disuse of the muscle, and I know that the subscapularis muscle is playing a role. So x-rays, okay? A lot of the primary care physicians will actually order these prior to coming to my office. If you haven't already had one, I'll order it myself. But I like to get 3 views because each one gives me a little bit more information. So here's the ball, here's the socket, there's that acromion bone, and this is that subacromial space where the rotator cuff lives, okay? If I see bone spurs up here in the subacromial space, if I see the ball of the socket is superiorly migrated, so not necessarily sitting concentrically on the glenoid, I know that impingement may be playing a role in your problem. This is a scapular Y view, so a sort of a shot from the side, this way if the x-ray beam was pointed this way, and it allows me to see any bone spurs. It allows me to evaluate your acromion. If you can appreciate in this patient, they have what I would call a hooked acromion. This bone right here, instead of going straight up, as we'll see when I talk about subacromial impingement, it actually comes down. And that's a normal anatomic variant. There are 3 types, and we'll go over those, like I said, in just a couple of minutes. But if you have a hook like that, if the rotator cuff lives up here, you raise this ball as you bring up your shoulder, it's going to get pinched against this bone. And so it serves as a extrinsic compression factor to the pain that you get when you do overhead activities. And then this is an axillary view. I don't know if you can appreciate this too well, but there's a ball sitting here on the socket, and it's sort of like a bird's eye view. This is a good view to let me know whether or not osteoarthritis may be playing a role in your pain. So other advanced imaging sometimes comes into play if I feel that it may be necessary to do a little bit more investigation and look at the muscles, the tendons, and the ligaments around the shoulder. So x-rays are important because x-rays allow me to look at bone. The clues that I talked about before are certainly relevant, but this gives me a little bit more information in terms of what the muscle, the tendon, and the ligaments look like. So what's the etiology of rotator cuff problems? Like I said before, and we've touched on this a little bit already, impingement syndrome is a huge issue. The impingement interval is this space up here where the rotator cuff lives in between the ball and the roof of the shoulder. Normally it's narrow, but it becomes maximally narrowed when you bring your arm overhead. Any condition that further narrows that space can cause pinching of the rotator cuff. So causes of shoulder impingement: subacromial bone spurs, loss of rotator cuff strength. So if the rotator cuff loses its strength, it loses its natural ability to keep the head centered on the socket. So what happens is the rotator cuff gets weak, the head starts to move up, and then it starts to narrow this space. So it's like a vicious cycle. Thickened or calcified CC ligament, this is one of the ligaments in the shoulder from trauma, can also cause impingement. And then these are the two types of acromions that you run into trouble with people who have impingement. The type 2, which is curved, and the type 3, which is hooked, compared to this type 1 anatomic variant that most people have when you look at the acromion bone. So in terms of the classification of impingement syndrome, it really depends upon your age. Stage 1, usually seen in patients less than 25 years old, typically an overuse injury, and is characterized by a lot of hemorrhage within the tendon and the muscle, and you can see that on MRI. This is usually reversible. I can ask the patient to make some activity modifications, put them on an anti-inflammatory, start some physical therapy. Usually it goes away with time. Patients 25 to 40 years old, they can actually have irreversible changes, something we call fibrosis, where you develop scarring within the tendon itself. And then so in stage 3 patients have irreversible changes, and then with general chronic attrition over years, you can actually develop real rotator cuff tears. So impingement syndrome, how does it present? People usually walk into my office, they complain of ache or burn at the deltoid insertion right here. So even though the problem is up here, patients actually feel the problem down here. It doesn't make much sense, but it's usually a clue. Pain with overhead activities like we talked about before. Usually there's really no traumatic incident that they can recall, just sort of a gradual insidious onset of pain. Night pain really clues me into rotator cuff problems. And typically they don't have weakness unless there's actually a real tear that has caused some atrophy of the muscle and poor dysfunction or poor function. So rotator cuff tears, how do they present? Sometimes people come in with trauma. Sometimes it's gradual trauma. So over the years with gradual overhead activity, people start to develop these small micro tears that then develop into larger, bigger tears, okay? Once again, an ache or burn at the deltoid insertion, pain with overhead activities, night pain, and weakness is going to clue me into whether or not there's actually a real tear versus tendinitis. So how do I treat this? Chronic and old tears versus acute tears or tears in younger patients. So with the chronic tears in the older patients, I always try a brief period of activity modification, physical therapy, non-steroidal anti-inflammatory medications, and sometimes I even include an injection into the subacromial space, which is this space up here where the rotator cuff lives. We'll talk a little bit about why the injection or when the injection comes into play, but a lot of people tend to get better with this. I'm always amazed at the number of people who I send to physical therapists come back in 8 weeks and say, you know, I feel so much better. You know, I'm glad we were able to avoid surgery. And obviously, you know, I'm a surgeon. I love to do surgery, but if we can avoid it, I think it's in everybody's best interest. So therapeutic injections, people always ask when they're in my office, what does that consist of? What does it do? What's the purpose? So it usually is a local anesthetic. Personally, I use a little bit of lidocaine, a little bit of marcaine, so similar to the things that your your dentist uses in his office, and then a little corticosteroid. Now, the local anesthetic is going to flood the subacromial space when I inject it and help take away the pain in the immediate phase, okay? The steroid, however, is an anti-inflammatory, and it's being directed to the area where there's essentially a forest fire. The shoulder is angry. And if you go in there, and I see this a lot when I do arthroscopic surgery, it's very red, angry, inflamed looking. And the point of the steroid is essentially put out that forest fire. So it's actually helpful because it's both therapeutic and diagnostic. When I do it and patients come back and tell me that they actually had a lot of relief, I know that the problem is up there in the subacromial space. So I reserve this treatment for patients who have partial tears that may not necessarily need surgery, patients who may be poor surgical candidates, meaning that even though they have a rotator cuff tear, they may not be the most suitable candidate for undergoing general anesthesia, because general anesthesia does have inherent risks as well. And then people who come back that have tears that we know about but fail to improve with physical therapy, activity modification for a while, the non-steroidals. The injection is always sort of the last resort to try and putting out that forest fire until we have to maybe talk about doing a surgical procedure. So what do I usually tell my patients about conservative care, conservative management? They can obtain good results with focused physical therapy designed to strengthen the rotator cuff and the scapular muscles. This will stabilize the glenohumeral joint and prevent additional or future injury. What do I focus on and what do I tell the physical therapist that they need to do? Mostly isotonic stretching and isometric strengthening. So not necessarily a lot of strengthening that requires a lot of movement, because that's going to make the shoulder sore, but holding the muscle and contracting it to keep the muscle firing, but minimizing movement so there isn't a lot of generation, so I'm not really stirring up that inflammation. And then lastly, I talk about rotator cuff tears, and there's a lot of studies now in the orthopedic literature that suggest that over time, these tears can get bigger. You can either have another traumatic acute event that can make it become bigger over in that single incident, or over time, slowly they can enlarge as you just use your shoulder to do regular everyday activities. So in those cases, surveillance and close follow-up is probably indicated. In those types of patients, I usually tend to get an MRI every year, year and a half. So this is a rotator cuff tear, okay? This is an arthroscopic view. This is the tendon right here. This is the ball, okay? And I'm seeing the bone underneath it because the tendon, which should be attached right here, has torn and retracted all the way over here. And so how do we fix that, okay? When we're in there with the camera, what we do is determine the best places to put our stitches, put them all along the rotator cuff tendon here, and then tie them down using arthroscopic techniques, using these anchors that have the sutures attached to them. And then over time, what we hope, and this doesn't always happen, but we hope the rotator cuff tendon heals back to the bone. So what do I tell my patients about surgery? So if we were to do a procedure like that, and this is very different from the way we used to do it almost 15 to 20 years ago, where we used bigger, larger incisions, more open techniques where you had to cut through a lot more muscle, a lot more painful. This is actually a fairly straightforward procedure and a bread and butter procedure in terms of what a shoulder surgeon or a sports medicine surgeon would do. You only have to be in the sling for maybe about 4 weeks. For the larger tears, I usually tell patients maybe 6 weeks if I really want to give the tendon a little bit more time to get a little bit more sticky and heal down to the bone. Total recovery can take up to about 6 months. You're generally not going to feel or plateau to the point where I think you're going to be happy with your outcome until about 12 months though, okay? Pain relief is predictable. However, function and range of motion isn't always as predictable. So some patients who come in are avid tennis players, I can't necessarily guarantee them that they'll always be able to do that overhead serve. And they may need to sort of modify their type of serve to get back to doing the things that they want to do. But in general, most people can return to their pre-injury activities. So what are some things that go hand in hand with rotator cuff problems? Biceps tendonitis is one of them. This is the rotator cuff tendon up here. Here's the biceps tendon here. The problem is that with rotator cuff problems and general inflammation in the shoulder, the biceps tendon usually tends to be affected as well. This I treat with non-steroidals and an injection. PT is always the mainstay. And then if we do need to do a surgical procedure, there are two types of procedures that you can do to address the biceps tendon if it's a problem in conjunction with rotator cuff problems. That's either a tenotomy, where I just cut the tendon and take it out of the shoulder joint so that it's no longer living in the shoulder. I tell patients that the consequences of that are that with repetitive flexion and forearm rotation, sometimes you can get a little cramping. And then the other thing that tends to be more of an issue in men is you can get something called a Popeye deformity, where the biceps muscle has lost its normal resting tension and develops a little bit of a bump here that's prominent if you compare it to the other side. Some people don't like that, and it's a little bit of a cosmetic deformity. So in that case, what we would do is a tenodesis, where I would cut the tendon, then make a smaller little incision right about here, and then reattach the tendon to the bone, lower down on the bone here, as opposed to in the shoulder up here where it's actually serving as a pain generator. So the other thing that can go hand in hand with rotator cuff problems is adhesive capsulitis. Has anybody ever had a frozen shoulder? It's one of the most painful things that I treat, and it's incredibly frustrating to patients because the real treatment is just time. It does get better with time. You should never let anybody convince you to operate on a frozen shoulder because it won't get better. This is associated with trauma. So what happens is if there's an injury to the rotator cuff, you all of a sudden you start to favor that arm. You don't use it as much as you would otherwise. And over time, it develops into a frozen shoulder. It's common in people who have systemic disorders like diabetes, thyroid problems. And for some reason, we don't know why, but it's more common in middle-aged women in their 40s to 60s. And it's characterized is pain. Okay, people usually literally wake up one morning, have searing pain in their shoulder. No real reason why. The pain turns into pain and stiffness. All of a sudden, if it's a woman, she comes into my office, it was painful for a couple weeks, and now I have trouble putting on a bra or buttoning a shirt. Very simple things. That pain and stiffness turns into just stiffness. And that's one of the most frustrating things to patients because they lose function of the arm. And typically, the last stage is called thawing, when it starts to unfreeze and you get your range of motion back. It's not necessarily painful during that particular period, but the range of motion comes back very slowly, so it can be pretty frustrating. And then the last thing that I'll talk about briefly is calcific tendinitis. This is a problem with the rotator cuff tendon itself, where you've had a deposit of calcium in the rotator cuff tendon. It causes a lot of inflammation, a lot of pain, a lot of night pain once again. And it's almost, when you see a patient, the exam is almost like a rotator cuff tear, but there's really no tear. It's just this calcium deposit wreaking havoc on the shoulder from a lot of inflammation. So patients with this tend to get better with subacromial injection, which I'll do in the office, or send to a radiologist, because radiologists can actually do it under ultrasound guidance and actually decompress that little calcific deposit with a needle and then inject the steroid. So it just depends upon what happens to be more convenient for the patient. So last but not least, we'll talk about rotator cuff arthropathy. This is arthritis of the shoulder that develops when someone does not have a functional rotator cuff. Remember we were talking about before, the rotator cuff lives up here and it keeps the head centered on the socket. So when you lose your rotator cuff tendon, it tears away from the bone here and now lives over here. The bone starts to migrate up on the socket. And that causes a lot of increased forces here at the top of the socket and arthritis. So the wear is superior, and the similar presentation to regular osteoarthritis, but patients typically have worse shoulder function with regards to range of motion. They come in and they're not able to lift their shoulder. They actually try to swing their body to actually get some sort of motion with regards to the shoulder, but they just can't. So until about 15 years ago, there was really nothing to do about this. We would tend to manage people with anti-inflammatory medications, subacromial injections, but now we have a real solution with regards to a special type of shoulder replacement, and it was designed in France. It's been over there for almost about 20 years and was recently FDA approved over the last 12 years, and now we're starting to do a lot more of them here in the United States. It's the reverse shoulder arthroplasty, and it's a very clever way of reversing the ball in the socket. So typically what I do in a normal shoulder replacement, and I'll go back to this view here, is cut the bone here and then put on a metal ball and then put on a plastic socket where the bone is here. But in a reverse shoulder replacement, I reverse the parts so that the deltoid muscle, which is the muscle that lives out here, now functions like the rotator cuff biomechanically, and it's a very clever way of using the biomechanics of the center of rotation of the shoulder to make the deltoid muscle the main activating lifter of the shoulder. Okay. So here's a 77-year-old man who had right shoulder pain. He could actively forward elevate to about 30 degrees. Okay. Very, very unhappy guy. So this is the type of shoulder replacement we did. It's a lot of metal. But instead of the ball being here, where I would normally put it, it's now on the socket. And then the socket is actually where the ball should be. And people can actually get quite good function from this. Most reliable thing is pain relief, though. So what do I tell my patients about shoulder arthroplasty? Predictable pain relief. Function, not as predictable. I'm happy if patients come in after surgery about a year out, maybe about 110, 120 degrees. Some patients get up here, some patients get down here. But most people with this problem, with this rotator cuff arthropathy, are actually fairly happy just to get rid of the pain. And then what's interesting is that the indications for this type of shoulder replacement are expanding, and we're using them a lot more in fractures, but it does have a high complication rate, so it's not a benign thing, and it's something that I talk to patients about over several visits just to make sure that it's something that they want to proceed with. So take-home points, I think number one, the rotator cuff muscles work together to actively move and stabilize the shoulder joint. Not all shoulder pain can be attributed to the rotator cuff. We talked about a lot of other things, the biceps tendon, calcific deposits, adhesive capsulitis. A skillful physician will perform a detailed rotator cuff test to determine whether or not the rotator cuff is the culprit. In my hands, if there's no weakness, and I think the rotator cuff is involved, I try PT first. Scapular strengthening and a specific type of rotator cuff protocol that all of our good physical therapists around the community are familiar with. If there is weakness, I refer them to get an MRI to basically look at the tendon itself, determine what the specific pathology is, and have a talk with them about whether or not we should try physical therapy first to try and strengthen up the other rotator cuff muscles to compensate for the one that may be torn, or if we should maybe talk about doing surgery a little bit faster because I think you're a good candidate and the tendon may have a good chance of healing back to the bone. Partial tears in my hands, I treat non-operatively. Okay, full thickness tears, I do try to treat them non-operatively after about 6 to 8 weeks. And patients who come back to me saying that they're not having any sort of improvement whatsoever, that's when we talk about a surgical procedure. So in young patients, I tend to be more aggressive since the tears can slowly enlarge over time. And then lastly, arthroscopic surgery provides reliable pain relief and good functional outcomes. But it's always a it's always important to set very realistic expectations, because sometimes a very debilitating injury like this can change your life and take you from playing tennis one day to not playing tennis the other day. So that's something we talk about in the office as well. All right. So with that said, I will take some questions if you guys have any.
Do you recommend daily home exercise programs as you continue forward after therapy?
Yes, absolutely. You know, I depend on the physical therapist to essentially set the foundation for you and work with you over about a time span of about 6 to 8 weeks to make sure that you're actually improving. Okay, so let's say you do improve. You come back to see me at 8 weeks and you say it's feeling a lot better. That's when I have a very serious conversation with you about making those types of exercises a daily part of your regimen.
And then I would expect, if I'm doing that faithfully, that I'm going to slowly eliminate more and more of the pain and slowly improve the range of motion.
Correct. Yeah.
Thank you.
Yeah.
Do you know women's softball where they pitch like this? And I have a 10-year-old granddaughter that's pitching now. Do you see problems if they continue that over a long period of time?
That's a great question. There are very different mechanics involved in the softball throw compared to the baseball throw, which is why, and I actually take care of the women's softball team at UCLA. We have 3 pitchers. We have about 9 pitchers on the men's baseball team. The girls can throw, because of the mechanics, they can throw back-to-back games. Never an issue. Men, it's an overhead throw where they require extreme motions of abduction and external rotation. So when you cock back the ball, there's a lot more force on the rotator cuff. And it's also the position that we were talking about before, where the rotator cuff gets pinched in between the ball and the roof. Very different in the softball throw. You don't see that type of impingement. So softball players tend to get a little bit more strain in the biceps tendon. Baseball players, a lot more problems with the rotator cuff and the labrum as well, which we talked about very early on in the talk. So a little different with regards to the mechanics. So girls a little more predisposed to a different set of injuries. Sure. You know, and we're making a lot of efforts now, especially in that age group, to come up with pitch counts, discourage young pitchers from throwing things, and this is in more in the little league phase with boys, but discourage them from throwing curveballs at 10 years of age. It's just too much stress on the shoulder, the elbow, and things like that. Maybe not pitching back-to-back games, limiting the number of pitches that they throw in a game. Those are the types of things that we're really trying to get out there to prevent injury, because we're seeing this rash of problems now where 18-year-old kids make it to the majors, and everybody's heard about Tommy John surgery now. Why are so many patients, young kids, requiring Tommy John surgery by the time they get to the majors? It's usually because they've been throwing their entire lives. Yes?
How long are you hospitalized if you have the arthroscopic show?
Sure, yeah. The arthroscopic procedure, if you are a healthy person that doesn't have any heart problems, lung problems, general sort of issues with things like hypertension, it's an outpatient procedure. If you do have a lot of medical problems, I would talk to the anesthesiologist and ask them if you would require about 24 hours of monitoring post-operatively, just to make sure that there weren't any post-operative effects from the anesthesia. So it's more an issue of the anesthesia than the actual surgery itself. No, if you were a healthy 75-year-old person, no medical problems whatsoever, you told me you walk 2 miles a day, you ride your bike, you're in and out the same day. In and out the same day. Age has nothing to do with it.
80 years old and you replace it.
Doesn't matter. You'd still go home the same day. Unless you wanted to stay. I mean, I guess we could talk about it. Nobody likes hospital food, though. Yeah.
When he replaced it, I was doing that.
That is a different procedure. That is not an arthroscopic procedure.
No, I know.
Yes.
When I first started having rotator cuff issues, I would say about 5 years ago. And in the course of the 2-3 years that I was seeing the doctor, I got a couple of cortisone shots and it helped. And everything started here with burning. And, then I had less movement. And I haven't really seen a doctor about this for the last 2 years, so I'm kind of so-so. But when he did some x-ray, he said I have arthritis in my neck, and he showed me this here,
Yep.
but not here. So would that also affect it?
Well, it depends upon your physical exam, but if you are a person that has some arthritis in your neck, you are a person that I would really want to pay specific attention to in the office with regards to a good cervical spine exam. Okay? I'd want to make sure that I ruled out any nerve problems in the neck that were then causing the pain to run down to the shoulder. Okay? So it's a very tricky thing trying to discern whether or not the pain is coming from the neck or the shoulder. And using all those tests, which I was describing before, you can usually really pick it up.
So then, I don't belong to UCLA, I'm part of Kaiser. And my physical medicine doctor moved away and I never kind of followed up. They just gave me exercises and things which I don't do anyway. But I just have a problem at night where, the range of movement, it's mostly coming the elbow. As opposed to here.
And it never really goes beyond the elbow.
Sometimes it does.
Sometimes?
Yeah.
And you ever get any numbness or tingling in your fingers? Yeah, so those are things that usually clue me into the shoulder.
Yeah. Oh, really? Because
Yeah.
I get pain in this joint. It's really good.
Down to the elbow?
Yeah.
Yeah, the shoulder pain can go all the way down into the forearm, into the hand. It's very funny that way.
And it wouldn't be connected, let's say if it comes all the way down to the wrist, to the carpal tunnel.
That's something completely different, but that's usually, so if you had a carpal tunnel problem, that would cause pain in the hand.
Also here in the wrist. Also here.
Correct, so the carpal tunnel is in the wrist, but it's compression of the nerve at the wrist, and the symptoms are usually felt distal, so far to where the carpal tunnel actually is.
But not up to the elbow.
No. A carpal tunnel would not cause pain up the arm, cause down the arm.
Okay, so then this must be connected here.
Exactly, yeah. Yes?
What do the numbness in the fingers indicate to you?
So numbness and tingling in the fingers, fingertips clue me into the neck again. Nerve problems, okay? If it's in a specific nerve distribution, then I'm thinking neck, and that's someone I would get neck x-rays in, pay specific attention to a neck exam, and if I thought that the numbness and the tingling was actually coming from the neck, I would refer you to a neck specialist as opposed to a shoulder specialist.
Do the tears ever get better over time as opposed to enlarging?
No, they don't heal. Once it's torn, it's torn. Yeah, they don't heal spontaneously, but there's a lot of literature now that shows that they can get bigger over time, and in younger patients who have who are particularly active, I do like to be a little bit more aggressive about following them more closely so that we don't make a tear that is repairable and irreparable tear. Because once those tears become so big, I can't stitch it back together like in that picture that I was showing you before. Because the tissue, if it pulls away from the bone, it sits there in space for so long, it loses its elasticity. And so it scars into the other tissue, and it's hard for me to pull it back over to the bone. So in that instance, I'd rather get it to it sooner rather than later. Make sure we could repair it.
For the tingling in the fingers, and you say it's a neck problem, do you think chiropractic can help with that?
Yeah, I do think, a lot of my patients see chiropractors for years, and usually the chiropractors, when they think that whatever they're doing with regards to the manipulation isn't helping anymore, we'll usually send them on to us. So some people it helps, some people it doesn't, just depends.
Can the physical therapy create tears where there were none, or I'm assuming it can make a tear worse?
Physical therapy?
Yeah.
No, physical therapists usually aren't that aggressive. The point of physical therapy is to get your range of motion back in a very slow, supervised, and controlled fashion. Not to push you beyond your limits to the point where it's actually becoming more painful. And if it is, that's obviously something that you should tell your therapist, who will then relay that to the doctor so that you can be re-examined. Yes? Yeah, sure.
A question, when you do the arthroscopic, does the tissue blend in and regrow like bones, or no?
So the tissue heals with poor man's scar tissue. So it forms this special type of scar tissue that bridges the gap between the tendon and the bone itself. So it's not like it's regrowing new tendon, but what it is doing is it's forming a special type of scar tissue that allows it to stick back to the bone. It's not as strong as the original connection between the tendon and the bone, but it is enough to get rid of the pain relief and give you your strength and your range of motion back.
So because it's joint,
Exactly.
it's not apart.
Mm-hmm, yep. Yes?
What does arthroscopic mean?
It means minimally invasive.
I have a rotator cuff tear, and since I'm back from my vacation, I haven't been able to come and see you yet, but I do about a half an hour of swimming every day.
Mm-hmm.
But I do just the back stroke. It doesn't bother me at all.
Mhm.
However, like this kind of motion does, and
Yep.
I don't even fall.
Yep.
Does that irritate my shoulder more, or is it okay for me to continue?
That's okay. I like to tell patients that, it is as simple as letting the pain be your guide. If it's not bothering you, then that means that particular motion, you're not seeing any impingement between the rotator cuff and the roof of the shoulder there. So if it doesn't hurt, yeah, absolutely. And the motion, the daily motion, and the strength training from the actual swimming itself is actually very important to keep it strong and centered on the socket like we were talking about before.
And the other thing is the tingling in the hand, or
Mhm.
numbness. I do get that at night.
Yep.
only.
Mhm.
And it goes away real quickly once I start moving. But
Mhm.
that is there. So would that have to do with the rotator, or might that be, my neck may have slight carpal tunnel?
That's something I would rely on my physical exam to really determine. But it could be either. It really could be.
Or neck?
Or neck. Yeah. Yeah. Yes.
I've been taking acupuncture. They tell me that would help, but I've been doing it a long time. Sometimes it gets a little better, sometimes it does nothing. So I'm beginning to think I'm just wasting my time.
Mm-hmm. With the acupuncture. Yeah, I mean, that's one of those things where I tell patients it can't hurt and it might help. So if financially it's not a big problem for you, and you have the time and it's convenient for you to do it, then I have no problems with it. But sometimes you need to really work with a doctor and a physical therapist to get to the root of the problem, and determine, with some advanced imaging, X-rays and MRI, what that problem actually is, to really figure out how to address it.
Well, I've been seeing a sports doctor down in Santa Monica,
Mm-hmm.
but they never will say that this is a rotator cuff. But everything that you mentioned up there is what I'm having.
Mm-hmm.
And all that twice they've given me a steroid, injection.
They've done the injections.
And that goes for like 2-3 weeks,
Yeah.
and then
So that's the problem with the injections that we may not have talked about. So, people always ask me how long will they last. It's variable. Some people, I give them one injection and it'll last, I won't see them for years. Other people, you give them an injection and it lasts a couple days. So it is a roll of the dice. It's usually, it doesn't harm the rotator cuff or the soft tissue structures in the shoulder if it's done in a very, if it's done sparingly and not on a regular basis. So I reserve maybe 2 to 3 a year if they actually help.
And that's the max, right?
Correct, yeah. In my hands, that's the max.
What period of time passes before tissue becomes too inelastic to make it easy to operate?
Yeah.
Question.
That's a hard question to answer because you know, the issue with the rotator cuff is over time it gets stuck to other tissues too. So we don't really know the answer to that question. If you came into my office and you had an acute episode and you didn't want surgery, but I know that episode was related to the rotator cuff tear, I couldn't give you a definitive answer and say, look, Mr. Smith, you need to come see me within a year or else I can't fix this. We don't know the answer to that question. But if in acute tears that I know happen with a specific traumatic incident, I do recommend patients get those fixed because they're going to come back over very easily. And we know after years of research that those are the tendon tears that tend to heal the best. The chronic tears in people who had this just insidious onset of pain, and when we look at the rotator, when we look at the MRI, there's a little bit of fatty atrophy there. Those are the tears that I know are chronic, have been there a long time, and if I fix them, have a lower likelihood of healing back to the bone.
Again, you used the word long time. What's a long time? I mean,
That we don't know. It's on the span of years. To answer your question, though, it's on the span of years as opposed to months.
Okay.
Yeah,
Years, okay.
yeah.
What happens when you get in there and you think that it could be repaired and then it's too tight?
And you can't repair it?
Right.
That's when you can get creative as a surgeon and do some things to make it come over. Sometimes if it won't, you can bridge the gap with these special allograft tissues that we have. And it's up to the surgeon to really prepare for the case and know if that's something that he may want to use. The outcomes with those aren't as great as if you were using your own tissue to not bridge a gap. But sometimes just the arthroscopy procedure alone, where you just clean out the joint and not necessarily even repair the rotator cuff, can really give you years of relief. But that's obviously a concern.
And where is the FDA with two-parts injections?
In the shoulder,
Yeah. because
I think they're
heard
still
that
working on
they're
those studies,
doing it,
yeah.
and it is fabulous.
Yeah.
And if they had said I needed surgery, since those injections, I have absolutely no pain.
yeah, still not approved in the shoulder.
Why?
Well, it's just the studies aren't there to support it yet. Once the studies come along,
If they don't let us have them, how can they, I mean, I'm not faulting you for that, it just seems, hey, it really works, why is this not
Right.
being approved?
right? Yeah, you know, once we have the research, usually it takes a good, even after that, a couple years for it to actually get approved. So that's the good thing about, you know, we were talking about the reverse shoulder replacement. They were doing that in Europe for about 20, 25 years.
I was just going to ask, do they do it in Europe? I'll go back right now.
Well, we do it here now. We do it here now. We're just, you know, we take things a little slower, I guess.
Thank you.
Sure. Yes.
Are the injections that you use in the shoulder the same medicine that is used in the hips and the back?
Well, it's the same concept, yes. Same. You use a local anesthetic and a steroid. You can use any type of steroid. There's various types. There's Kenalog, Depomedrol. There are various types that you can use, but same concept. Steroid and a local anesthetic.
Thank you.
I'm not going to answer that question. If you need a surgery, would you go to private?
If I needed surgery, would I go to Kaiser? I'm on camera here. This is being video recorded. Can I leave that one alone? Obviously, I'm biased. Come on.
Just say the loyalty you say.
Exactly. Exactly. Yes.
Can the steroids be taken orally?
They can. Some primary care doctors prefer to give patients oral steroids. I don't like the systemic side effects of taking a pill. I like the injection because I can direct it right to the spot where it needs to be. And it doesn't have the same side effects of, other parts of your body. Exactly. Yeah.
Are you through UCLA Westwood or Santa Monica?
I practice at both. Yeah.
You mentioned diabetes and thyroid issues that may further complications or cause certain symptoms in women. Can you clarify that or give additional information in regards to that?
Yeah, so that was with regards to a condition called the frozen shoulder or adhesive capsulitis. People who are generally middle-aged women have thyroid disorders or diabetes are predisposed to that particular condition. We don't know why, but they are. So, a woman that falls into that category essentially would have 3 strikes against her. And I see that a lot in my office, unfortunately. Yes.
Are men affected in as much same way with diabetes?
Yes, exactly. So if you have diabetes, you are predisposed to getting a frozen shoulder.
Any difference between type 1 and type 2?
No. Yes.
If you accommodate, how big of an issue is that?
How big of an issue is surgery?
Yeah.
It is a big deal. You would have to stop the Coumadin before you had a surgical procedure. Otherwise, you would bleed a lot during the procedure. So we would, what I tend to do is coordinate things with your primary care doctor. If we had a conversation where you would need surgery, I would send you to your primary care doctor, let them know we were planning on doing a surgical procedure, and then they would safely stop the Coumadin for a brief period of time right before the procedure. You'd have to get your blood drawn to make sure that the blood levels were normal and that the blood wasn't too thin. And then we would start you right back on the Coumadin as soon as the surgical procedure was over. All right.
Another question.
Yeah.
If someone has a torn rotator cuff, we will bypass, skip Kaiser, how much will it cost? Roughly high and low. Just a rough figure.
Roughly how much would it cost
Just a rough figure.
to come to UCLA? Or I honestly don't know the answer to that question. I really don't. I would direct that question to your insurance to ask them.
Sure, yeah, it won't pay. I have to pay the whole pocket.
Okay. Well, there are people in the billing office at UCLA who can answer that question for you. Yeah. All right, guys. Well, I hope that was helpful.
Thank you.
All right.
Thank you very much.
You're welcome.